Good afternoon and welcome to today's Grand Rounds. Today I have the pleasure of introducing Dr. Brooke Carterberry. Dr. Arterberry received her PH.D. from the University of Missouri in counseling psychology, and she is currently an assistant professor at Iowa State University. And CME committee is quite pleased and grateful that she was able to accept our invitation today to provide us with a review of adolescent and young adult drug use and interventions. And please join me in virtually welcoming Dr. Brooke Carterberry. Thank you.
Hello. Thank you so much for that introduction. I appreciate it. And I am very excited to be talking to you today. I want to extend a warm welcome to all of you for being here. By trade, I am a counseling psychologist, and I have specific training in addiction science and substance use disorder treatment. I want to make sure that you have access to the references for this lecture. They've been provided to you through the handout section. Additionally, I've made a few tweaks to the presentation and not anything too extreme, pretty minor, but I wanted to let you know that if you've printed out the handouts beforehand, they might be slightly different. So I'd like to talk to you today about adolescent and young adult drug use, prevalence and risks, assessments that you can use in your practice, and intervention efforts that we have available for our adolescents and young adults who are experiencing problems associated with their substance use. So let's go ahead and get started. Young adult and adolescent drug use is extremely common. Indeed, alcohol, cannabis, and tobacco are the most commonly used drugs in this population. For example, among 12 to 17-year-olds, 28% have tried alcohol by the 8th grade. 45% of those in grades 9 through 12 have reported cannabis use. 41% of those in grades 9 through 12 have reported trying cigarettes, and 15% of 12th graders have reported non-medical prescription drug use. And by young adulthood, these rates are going to differ by educational status. So for college students, heavy drinking becomes more prevalent, with approximately 32% reporting 5 or more drinks per occasion. Approximately 20% of males drink 10 or more drinks per occasion, and approximately 10% of females drink 8 or more drinks per occasion when they are drinking alcohol. Additionally, college students are more likely to engage in prescription stimulant misuse and are more likely to initiate cannabis use. In comparison to their non-college peers engage in prescription opioid misuse, prescription sedative misuse, prescription tranquilizer misuse, cannabis use, other illicit drug use such as cocaine or heroin, and tobacco use more frequently than their college peers. However, adolescent and young adult drug use is not without harms. Alcohol has been associated with injury, death, suicidal behavior, motor vehicle crashes, academic problems, and social problems, where approximately 2,000 students die every year from alcohol-related causes. Approximately 100,000 sexual assaults occur each year that are related to alcohol, and approximately 2.8 million young adults drove while intoxicated. Furthermore, cannabis has been linked to cognitive impairment, specifically in adolescence, where the effects appear to be irreversible and in terms of IQ and ability to process information. There's also academic problems, social problems, and motor vehicle crashes associated with cannabis use. Tobacco is associated with short-term and long-term poor health outcomes and is considered a gateway drug. And finally, prescription drug misuse, specifically prescription opioid use, is associated with an increased risk of injection drug use and overdose. Due to the high prevalence and severe consequences associated with drug use, it is so critical that we understand the risks associated with it and the efforts to reduce problems associated with substance use. So therefore, this lecture reviews some definitions that are going to be important for you to understand drug use. We also will talk about adolescent and young adult vulnerabilities and risks to drug use and consequences related to that use. We will also be talking about how to assess for substance use behaviors using quick, valid instruments. And we're going to discuss intervention efforts that are designed to decrease drug use and related problems among adolescents and young adults. So let's take a moment to discuss some important definitions that are going to help you better understand the lecture. So first, let's discuss the importance in understanding substance use disorders, or SUDs. Substance use disorders are recurring problems that affect multiple areas of life for individuals. So the criteria for diagnosing a substance use disorder is based on the 5th edition of the Diagnostic Manual of the American Psychiatric Association. Of the 11 criteria, a person must endorse at least 2 within a 12-month period. Diagnoses of SUDs are associated with long-term problems and earlier death. So let's review the general criteria that are used to determine a substance use disorder. So these criteria include the following. There must be important social, occupational, or recreational activities that the patient has given up or reduced because of their substance use. Recurrent substance use in situations in which it is physically hazardous. Having a strong craving or desire or urge to use the substance. Continued substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. Substance use that is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. A great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from the effects of the substance. Substance is often taken in larger amounts and over a longer period of time than the patient actually intended. And recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. Persistent attempts or one or more unsuccessful efforts made to cut down or control substance use. And then we also talk about tolerance and withdrawal. Tolerance is defined by either having to increase the amount of the substance in order to achieve intoxication or the desired effect of that substance, or diminished effect with continued use of the same amount of the substance. In terms of withdrawal, this is manifested by a characteristic withdrawal syndrome for the substance. You may think of alcohol withdrawal within the context of this. This is the one that I think we think of most commonly. Additionally, the same or a closely related substance is taken to relieve or avoid any withdrawal symptoms. So those are the criteria associated with substance use disorders. And remember, the person must meet 2 or more of those criteria within a 12-month period. So now that we have a better understanding of what a substance use disorder is and how we diagnose a substance use disorder, let's turn our attention to adolescent and young adult vulnerability for substance use and substance use disorders. Substance use that begins in adolescence tends to predict later problems, where most alcohol use disorders specifically onset prior to the legal drinking age. And although some young adults will mature out, meaning due to increased responsibilities and other role obligations that begin to occur around the ages of 22 to 25 or even older, they mature out and they stop drinking as heavily and they reduce the amount of problems that they have, and they likely will not have an alcohol use disorder after that period of time. However, 1 in 3 people will still have persistent problems with their substance use behaviors. So this can be seen when we look at data from the National Survey on Drug Use and Health. What I have here is a graph that they provide that shows trends from 2002 to 2018. As can be seen, 18 to 25-year-olds have the highest prevalence of alcohol use disorders. Although 12 to 17-year-olds have the lowest prevalence, it's still 2 to 5% of adolescents that will meet criteria for an alcohol use disorder. The one thing that I'd like to note on this particular slide is that young adults and adolescents are declining in their prevalence of alcohol use disorder. But the same cannot be said for other illicit drug use disorders. Similarly to alcohol use disorders, 18 to 25-year-olds have the highest prevalence of illicit drug use disorders. That's including prescription drug use disorders. And we noticed that 12 to 17-year-olds are at the second highest prevalence, which is about 3 to 4%. Meeting criteria for an illicit drug use disorder. And unlike what we see with alcohol use disorders, the trends are remaining relatively stable across time or increasing only slightly, but not at a significant increase. So you'll notice that this is only from 2015 to 2018, and that is due to the fact that the NIST have changed their survey methodology. And it's really beyond the scope of what we're talking about today, but I did want to note that. So finally, when we review young adults and their substance use disorder prevalence by education status, approximately 40% of college students that use substances and 45% of non-college young adults that use substances meet criteria for a substance use disorder. That is a staggering percentage. So let's talk a little bit about the risks for a substance use disorder. So these are both genetic and environmental. Environmental risks include peer substance use norms about how much peers drink or engage in other substance use behaviors. This could also include parental norms around substance use and alcohol use. In terms of genes, they explain about 50 to 70% of the risk. However, there's no single gene that we can target. These risks operate through intermediate characteristics, such as how a person will respond to the substance, as well as impulsivity. And impulsivity is acting without thinking, just doing. So a lot of times we think about impulsivity within the context of adolescents and young adults due to their brain development. So furthermore, a majority of adolescents are going to try tobacco, alcohol, and cannabis before they try any other drugs. And although alcohol is the most common substance used, once a person starts using other drugs such as cannabis, the likelihood that they are using another illicit drug is really high, and they're likely using alcohol as well. In terms of people who use cannabis, about 91% of people who use it also use alcohol or a tobacco-related product. So really, when we think about anything outside of alcohol, we're thinking of polysubstance use or use of multiple substances, especially when we think about cannabis. So those who start using before the age of 18 are more likely to have a substance use disorder by the age of 20. And 25% of adolescents that misuse prescription drugs by age 13 have a higher likelihood of having a substance use disorder in their lifetime. And of critical importance, and something that is really what I want you to remember, is that 9 out of 10 adolescents do not seek treatment for their substance use disorders or their problematic substance use behaviors. And only 1% to 2% of young adults will seek treatment. And this is across educational status. So even though college students may have more resources for treatment or brief interventions or interventions of any sort, they're at the same place as any young adult who's not in college. Access to resources is not the issue with this. So in essence, early onset of substance use increases the risk of having a substance use disorder in adulthood. In terms of alcohol use, drinking often starts and increases rapidly in adolescence, which sets the stage for substance use disorder development, and might be due to the decreased treatment seeking and utilization in adolescence and young adulthood. So adolescent and young adult brains also increase vulnerabilities to substance use disorders. An immature brain leads to a more efficient, mature brain as we age. And there's a back to front processing that occurs, especially in the immature brain, where emotions occur prior to planning. And it's kind of like, if you think about the gas pedal before the brakes, adolescents and young adults are just going, they're just doing, right? It goes back to that idea of impulsivity. The forebrain in this regard is critical for restricting behaviors, but the adolescent brain, the young adult brain, is focused on social interactions and peer affiliation. It's focused on novelty seeking and risk taking. So to recap, we've discussed that adolescents and young adult substance use is common, but not without harms. Furthermore, we know that adolescents and young adulthood are when substance use disorder prevalence is at its highest. There are possible risk factors that include early age of substance use initiation, There are genetic and environmental risks. Impulsivity is a risk, and the immature brain is a risk. And because you, physicians and healthcare workers, are on the front line, you are likely one of the first medical providers to know whether your patient is having substance use problems or engaging in substance use behaviors that are high risk. And this could be because you see them in the emergency department due to an injury or an overdose that's related to the substances that they're using. But more importantly, you see patients more regularly. You see them maybe annually for a checkup. Even if you aren't seeing them regularly in terms of annually, you're still more likely to see them scheduled in your offices. Therefore, you have the opportunity to quickly assess for substance use behaviors, especially among adolescents and young adults. So let's talk about now, like, how do you actually go about assessing for substance use behaviors or even problematic substance use behaviors? So as physicians and healthcare workers, you have different opportunities to assess or screen for substance use behaviors. You can do that through the emergency department, like I said before, or urgent care. You also may be seeing patients on an annual basis, and you can use these screeners for the annual checkups and with patients that you don't even see regularly. And when you do have a scheduled patient, consider screening for substance use if they have any type of health condition that we regard as having increased risk for engaging in substance use behaviors. Some of those conditions are depression, anxiety, ADHD, and conduct problems. Another factor for substance use screening includes alcohol-related health conditions, such as alcohol-related injury, changes in eating or sleeping patterns, chronic pain, and even gastrointestinal issues. Behavior changes are also important to note, especially among adolescents and young adults. So you want to be looking for mood changes, lower grades, and changes in peer group or skipping school or class on a regular basis. So if you have a young adult or an adolescent that you would like to screen for substance use, consider the following screeners that I'm going to go over with you. They've been validated with an adolescent population and with young adult populations. The first one I'm going to cover with you is called the S2BI. This screener assesses past year frequency of tobacco, alcohol, cannabis, and other drug use. The response options are never, used 1 to 2 times, used monthly, or used weekly or more. And these responses are used to discriminate between no use, no substance use disorder, moderate substance use disorder, and severe substance use disorder. And these are based on the DSM-5 substance use disorder criteria that we talked about earlier. One thing to note about the S2BI, this is available online, and so you could put it on an online platform. It's also available through the NIH, so you could have and scored as well through that online system. So you don't have to do any of the work. It's a quick screener. It's not going to take but maybe 5 minutes to fill out for the adolescent or the young adult. So if you're really concerned and you think that there is a substance use disorder that they possibly could have, this is a great screener that's very quick that you can use. Another really quick screener is called the CRAFT, and it's used by many physicians and in hospitals. The acronym itself guides the assessment. And this is one that I could very well see being used in an emergency department or urgent care, or even if you suspect that the person that you're talking to has some type of alcohol or substance use problems, or they're engaging in these behaviors. So to start, think of C. Have you been in a car or been driving while using drugs? R is the question, do you use to relax, like yourself more, or to fit in? A, do you use drugs while you are alone? F, do you forget things you have done when you've been using? F, have your family or friends said you should decrease your drug use? And T, have you gotten into trouble while you were using? If your patient says no to the first three, CRA, then you can stop the assessment. You don't have to move forward. If they say yes to any of those questions regarding CRA, then you need to continue on to the FFT. Another well-established screener is the BSTAD. This assesses for personal and peer past use of alcohol, cannabis, tobacco, and other drugs. Then it assesses for specific drugs based on patient endorsement of those drugs. And then finally, you assess for past 30-day use of all the drugs used in the past year. So this screener is a bit longer. It focuses specifically on substance use, and it would be best delivered using an online platform. It could be used if you have patients that are scheduled that you see more regularly, and they could fill this out. Again, using the online platform, it's a much easier scoring method. And in terms of assessing it in the moment, it's going to be more challenging to keep that in your head. So the craft might be a better approach to get at these substance use behaviors more quickly. The CAGE is another shorter screener that can be used in, again, an emergency department, urgent care, or when you're talking to a patient that you're concerned about in terms of their substance use behaviors. It was developed for alcohol, but really it can be used for any drug out there. So if you're concerned, or if you have some thoughts, oh, this person may be using cannabis, or this person may be misusing prescription drugs, you can go ahead and insert the drug that you want to assess for. Again, this is guided by an acronym, so it's easy to remember. Even the scoring is easier than the craft. So C, have you ever felt you needed to cut down on your substance use? A, have you been annoyed by others who are criticizing your substance use? G, have you ever felt guilty about your substance use? And E, this is the eye opener. Have you ever had to use a substance in the morning to help wake yourself up or reduce the effects of any of the substances that you used the night before? In order to score this, 2 or more affirmative responses to these questions means that there are potential problems that the person is having. This does not diagnose substance use disorders. So this is more about saying, okay, this person may have a substance use, have some issues with substance use. I'm going to refer them to a longer assessment. Maybe I have them fill out the BSTAD. Maybe I want them to have an even longer assessment, or even go into a brief intervention, which we're going to discuss here in a few minutes. And finally, the last longer screener that I'm going to talk to you about is the GAINS. This requires being filled out and scored. So again, this might not be suitable for the ED or urgent care, but used more for scheduled patients or those that you have real concerns about. There is an online version available, so that way you don't have to do the scoring by hand. It assesses 4 domains for diagnosis or treatment, including internalizing disorders such as depression or anxiety. It assesses for externalizing disorders such as fighting, substance use disorders, and the question is asked in terms of weekly use, and then also crime or violence such as stealing or driving while intoxicated. And moderate to high scores suggest the need for mental health or substance use disorder treatment. So this is a really great measure and assessment. Again, very quick. It only takes about 5 minutes for the person to fill it out. The challenging part would be for you, the physician, to have to score it. And so having it online and ready to be scored, so it gives you this information, tells you more globally what could be going on with your patient, and you can create a referral right then and there based on that score. So at this point, we have discussed adolescent and young adult substance use, that it's really common and it's not without harms. Furthermore, we know that substance use disorder prevalence is at its highest during young adulthood and adolescence. We also have learned about the possible risk factors and vulnerabilities, including early age of substance use initiation. We've learned about the genetic and environmental risks. We've learned about the risks associated with impulsivity and the immature brain. Additionally, we've covered several quick screeners that you can use, such as the CAGE and CRAFT, for assessing problematic substance use behaviors. So let's go ahead and start talking about interventions and treatment that are used for reducing substance-related harms and even substance use disorders among young adults and adolescents. So the first one I'm going to talk to you about is ESPERT, and it's a brief intervention that has been used in hospital settings. They're now starting to use it on college campuses, but it's one approach that if you want somebody to get in and get a really quick screen and get an idea of what kind of referral they need, this is it. It's really a neat intervention. So first, you screen for substance use via quantity and frequency. Then you provide a brief intervention lasting about 10 to 15 minutes. And it's designed to increase motivation to reduce risky substance use. Finally, you engage in the referral to treatment. This is to encourage the person to seek treatment if they're engaging in high-risk substance use and have substance-related problems associated with their use. So to go into a little bit more detail about how this is delivered, like I said, it's 10 to 15 minutes from start to finish. Like, it's not a long intervention. And it's best delivered when the physician or healthcare worker engages in kind of the following approach. So confirm your concern with the patient's responses to screening questions. Ask the patient's perceptions about barriers to quitting, about any potential relapse risk factors. Discuss with the patient about personal responsibility and that responsibility in relation to the consequences of their substance use, and provide non-judgmental advice and discuss the benefits of actually quitting. Next, you'll want to discuss potential treatment options and provide encouragement and support to the patient. Solicit commitment goals and provide education and resources to the patient upon finishing the intervention. So again, this is about just providing that space and that support for the patient to then make the decision about whether they are going to indeed follow up on that referral. The idea is to encourage them as much as possible to follow up with that referral. So there are other brief interventions that I wanted you to be knowledgeable about, especially because we are in Ames and there is Iowa State University right next door. And so you may be talking to more young adults that are in college. And colleges and universities have brief interventions available to students, usually for those who are mandated, but they can access these interventions voluntarily and they're free. So for young adults in college, these brief interventions are directed usually toward specific substances, focused mainly on alcohol and cannabis because these are the most commonly used drugs among young adults. These intervention approaches are more personal in nature, so they're going to ask specific information about personal use. They are tailored to risk and lead to a reduction in heavy drinking and related problems. These programs include education and feedback regarding the person's actual alcohol use or cannabis use and beliefs about alcohol and cannabis. They are delivered via video. There's a series that has about 5 videos they can watch. This is the longer version. They can be web-based, so they meet one time and then they're done, or in person, which is usually on average a 2-session intervention. The content of these interventions include psychoeducation about alcohol and cannabis and its effects on the body and interpersonal issues that may arise due to their substance use behaviors. We use this time to correct misperceptions about self versus peer alcohol use or other drug use. We help to correct false beliefs about alcohol and other drug use. And we also teach healthy coping skills, such as exercise, to reduce stress. Finally, at the end of these interventions, we provide strategies for safer alcohol use or other drug use. In terms of alcohol, this could be discouraging pre-gaming, discouraging drinking games, encouraging them to count their drinks, and encouraging them to alternate between alcohol and non-alcoholic drinks. Note that this type of intervention, these types of interventions are harm reduction interventions. At the end of the day, the student or the young adult or the adolescent must come to the point where they want to reduce their use. So next, let's talk about some treatment modalities or therapies for rehabilitation, specifically related to substance use disorders. The core of these are to change attitudes and behaviors. They are longer-term modalities, so this is not a brief intervention. They include motivational enhancement therapy, cognitive behavior therapy, contingency management, adolescent community reinforcement approaches, and family therapies. So let's start with motivational enhancement therapy. This is designed to reduce ambivalence and increase commitment to change. The patient discusses the positives and negatives of substance use, and there's a specific focus on the negatives that the person is experiencing regarding their use and problems. By highlighting and discussing what is negative about the substance use and how it's impacting their lives can be really helpful. A lot of times people are not as aware as what you would think about what these consequences are on their lives, especially in terms of adolescents and young adults who are not necessarily as future oriented as adults are. Cognitive behavioral approaches focus on cognitive and behavior changes. So some of the cognitive changes include helping the patient recognize their responsibility for their actions. We also talk to them about how substance use and problems can change. So there is some encouragement there, some empowering there about the ability to change these behaviors. Helping them understand that the main person that is suffering the consequences, it's the patient, it's them, not the other people around them necessarily. And change often requires help. So they're not alone and they don't have to do it on their own. Behavior changes include developing skills for relapse prevention, learning to control their thoughts and behaviors, and managing high-risk situations. So especially when you're thinking about adolescents and young adults and how we talked about they are focused on their peer affiliation, right? Their social interactions. And so high-risk situations could be interacting with friends that use substances and they're trying to stop using substances. So it's managing, how do you manage being in that situation? How do you keep yourself from using? Next is contingency management. It's focused on using positive reinforcement to change behavior through vouchers, prizes, privileges, or money when the patient is sober and remains sober. Note that this is usually used for inpatient and intensive outpatient substance use disorder treatment. It can be used as an adjunctive treatment, so it's used in combination with cognitive behavior therapy or motivational enhancement therapy, and is not really a standalone approach to treatment, but can be really nice because you're teaching them, or we're using positive reinforcement, right, to teach them to remain sober. Next is adolescent community reinforcement approaches. This is it's a combination approach, so you're using cognitive behavior therapy, collaborative community support, and contingency management. There are going to be 3 types of clinical sessions associated with this approach. The adolescent is going to see a counselor individually, so they'll be alone. The parent or caregiver also receives counseling, and then the family receives counseling. So there are 3 different types of sessions so that you can help them learn to communicate more effectively, so increase their communication skills, help them learn to problem solve, and engage in pro-social activities, not only in terms of by themselves, in terms of the adolescent, maybe going out with friends, but also as a family. And finally, family therapies include increasing parenting skills, increasing parental monitoring, increasing limit setting, increasing emotional attachment with parents, increasing communication skills, and reducing family conflict. Think about family therapy as a more global approach to assisting adolescents and young adults with substance use disorders. They're not necessarily having problems just within this individual microcosm. It is a much larger issue and it impacts more people. So whether rehabilitation or brief interventions work is a difficult question to answer, but it's hard to measure without double-blind studies. The intensity of substance use may naturally increase and decrease over time despite treatment, and many drug problems have spontaneous remissions. If we go back to thinking about that maturing out process among adolescents and young adults, it can happen spontaneously or due to other obligations or role obligations. We do know that the brief interventions, especially among young adults, have small positive effects in decreasing high-risk substance use behaviors and problems, and that's usually in the short term, so may last about 6 months. So in conclusion, we have discussed that adolescent and young adult substance use is common, but not without harms. Furthermore, we now know substance use disorder prevalence is at its highest during adolescence and young adulthood. Vulnerabilities include early age of substance use initiation, genetic and environmental influences, impulsivity, and the immature brain. Moreover, we have reviewed several really quick screeners that you can use, such as the S2BI, CAGE, and CRAFT for assessing problematic substance use behaviors. And finally, we discussed several treatment options for adolescents and young adults, such as SBIRT, motivational enhancement therapy, and brief interventions designed to reduce high-risk substance use behaviors and substance-related problems, including substance use disorders. And I want to just give you 4 takeaways from this lecture. Remember that adolescent and young adult drug use is common. Young adult and adolescent drug use can be harmful and result in substance use disorders. However, you have some really quick, easy screeners that are essential for referral to treatment that you can use. And there are several treatments for substance use disorders that currently exist. And finally, I want to thank Dr. Mark Shuckett from the Department of Psychiatry at the University of California, San Diego, and the Alcohol Medical Scholar Program for assisting in the development of this lecture. So, are there any questions? Thank you. And if anyone has any questions or wants to reach out, please feel free to email me at barterb@iastate.edu. Thank you very much.